So I'm going to share a challenging left main bifurcation disease in acute myocardial infarct. This is a challenging cases because we are going to discuss what the plaque morphology in this kind of acute MI and how to prepare the lesions and what is the stenting strategy and how to assess the result. So let me start. So this is 80 years old male presented with acute myocardial infarct. The troponin was elevated. And 2014, he had a PCI to LED, 2 stents, and PCI to circumflex, 1 stent. CVRF, hypertension, smoker, and dyslipidemia. You can appreciate here the ECG showed the ST depressions in inferior lead and avial ST elevations in avial, and then there is a ST elevation as well in the aviar. So this is really a very serious acute MI. So LVF was 46% with anterior hypokinesia, normal renal functions. Core angio showed triple vessel disease left main bifurcations, and syntax score was 25, Euro score 0.99. Patient was offered to have a CABG, urgent CABG, but he declined. So we decided to do PCI. So this is the diagnostic angio. You can see here there is a moderate disease of the mid RCA, and there is a disease, significant disease at the posterolateral. This is the left coronary disease. You can appreciate a very severe distal left main involving a circumflex and the LED. Sluggish flow at the LED. This is another view of the left coronary. So based on this information, we did a pre-dilatation using 2 millimeter balloon and then followed by IFOS assessment. This is IFOS run from LED to left main.
Yeah, we see the old stent, and which was okay expansion.
Yes.
And left main, we see the calcified nodule. So you may want to play again.
Okay.
Yeah, so starting at the distal, there is an old stent, and stent expansion is okay. Not fantastic, but I would say almost real, right? And not too much neointima inside, but vessel is much, much larger. And stent stopping here, and then that's already circumflex from the 6 o'clock, and left main, that's a very typical picture of the calcified nodule. So we have to remember, when we see the MI patient, we think everybody is thrombus. That's true. And we think most of the lesion is very soft because of the lipidic plaque and thrombus. But we have to remember 5% of the cases is actually very calcified, such as this case, calcified nodule causing the MI. So this is really typical calcified nodule causing the MI.
Okay, thank you, Dr. Akiko. And this is, we tried to assess the circumflex to left main, but I first got difficulty to go deep to circumflex. So we just got information at the ostial part of circumflex to the left main.
Yeah, just play.
Yes.
So at least we know calcium.
Yes, yes.
Sitting on the ostium of the circ. That's the point, right? So it seems to be the calcified nodule is really sitting in the bifurcation, which protruding to the left main and protruding the LED and also the circ. So seems to be this is really by IVUS definition 111 lesion.
So
yeah.
So
what do you think?
Can I ask Dr. Rowe for you to discuss about this case? What is your strategy after you see the bifurcation left main Medina 111 with the heavy calcifications?
Yes, I think so. Still, if we try to persuade the patients to go for cabbage if possible, but if we are to do PCI, then I'll make sure the patients have good hemodynamic support. I don't know what type of hemodynamic support you have in terms of mechanical circulatory support. I think regardless what the what they call the hemodynamic is before you proceed further, I think I'll make sure that is put in place. It's definitely Medina 111. We have to intervene the ostium of the circ, given the fact that it's calcified and badly diseased. I think we need some form of atherectomy. Because the LAD stent is so close to the ostium, I think orbital atherectomy, I think we shouldn't use that. I think it's a difficulty because it's absolute contraindication in terms of pre-existing stent. So I think rotational atherectomy is is the way to go forward. And certainly my skill is not as good as many experts in terms of directing into the what we call calcified nodules, but we'll try to need to make sure we control the wire bias to deal with it. Some people actually suggest IVL can work for calcified nodules or eccentric plaque, but I'm not too sure. I haven't done that many. Some less than 5 cases IVL. So I don't know whether the rest would like to make any comment. And in terms when it comes to stenting, I think it's upfront 2-stent strategy. And knowing Fauzi, I'm sure it's a DK cross. It's just like another day in the office for him. Okay, I think that's all I have to say. So I don't know whether anyone else have anything to add.
Thank you, Dr. Rowe. Dr. Lin, you have any idea of this? Dr. Lin?
Yeah, I think it's definitely the 1,111 lesion with calcium spot, and rotational atherectomy, I think, a little bit dangerous for this case. But I think maybe I would try some scoring balloon first to the Left-Main to circumflex and Left-Main to the LED, and then to see what happened with the IVUS, to see what happened after the this scoring or cutting balloon procedure. And then for stenting, I think I would choose Coulomb stenting for this Left-Main bifurcation lesion. That's my opinion.
Okay, thank you very much. Dr. Fauzi, please.
Yes, at that time I was surprised with the plaque morphology, and I avoid at that time. It is better I refuse to do PCI, but thinking that we have to do the best what we can do, and the plaque morphology revealed that this is a calcified calcium nodule, which is a calcified plaque. So we cannot avoid to let it be, but we have to do lesion preparation well before doing a stenting. Otherwise, the stent is not well expands, and then going to be worsening situations. So we decided to do a rotational atherectomy due to the flow at the LAD was sluggish. Then we chose the route from the Left-Main to circumflex. After several try, we can manage the burr can pass the circumflex. So I chose the 1.75 because we not only to modify the plaque, but trying to debulk as well. That's why I chose this kind of the burr size. And this is the post-rota IVUS.
From LAD,
Yes.
circumflex, sorry.
Yes, from circumflex.
Now you pass the IVUS into the circ.
Yes, any idea? Should we start the stent?
Yeah. Okay, so I think that's a very good picture, meaning that there is a very clear reverberation and polished surface, which is concave shape, which is coming soon. So let's go a little by little. So this is okay, calcium. Soon.
Okay.
Go ahead. that one here.
Yeah.
So 3 o'clock, you see
Yes.
the nice shape, which is concave. And then behind, you see the double layer or even one more layer. So that's really loop ablation. And when you see the loop ablation after the rotor, that's indicating that you polish the surface well. Because after polishing the surface, ultrasound can reflect much more than without. And then we start seeing this type of the loop ablation. And always we see the effect of the rotor at the site of the wire bias, which is IVUS is located. So you should look into where the IVUS is located. And then if you see this type of the loop ablation, you did a good job. And originally, you remember the calcified nodule is convex and then protruding to the lumen. But now you see some kind of the hole, which is, here. That's very different compared to before.
Dr. Akiko, may I ask you the questions? Like you mentioned about the liberation and the calcium crack on the IVUS finding. Do you think that only the liberation is enough for putting the stent on, or just proceed another balloon dilatations?
I think the answer is no, because loop ablation is really you polish the surface. And it's not indicating the stent calcium fracture. But when we look into the sequence of the IVUS or OCT, typically calcium fracture occurs at the site of the loop ablation, because I believe the surface of the calcium is the hardest. And then when you polish the surface, you have a more chance to make in the calcium fracture. So, but I think the very severe calcified lesion, you should see the fracture before stenting. That's really secure the stent expansion. That's my opinion.
Thank you. Please,
I would agree with Prof. Akiko as well. I think it's important to see the fracture before we put the stent. That's important.
So what do you think, guys? Whether we have to proceed to stent or we have to do a further predilatations?
For me, do the predilation first and protect the left main. So what you're doing, Dr. Fauzi, we are very exciting to see.
And then, as I mentioned before, that we have to do well preparations before putting the stent. So that's as Dr. Akiko said, that this is we confirm the successful rotablation. We can see the concave shape of calcium nodule and reverberations. So we perform further predilatation using scoring balloon, using to LED and to the circumflex, to high pressure scoring balloon. At the time, I chose a 2.5 15 millimeter score flag. Might be it is better using the high, size up the balloon. So, do you agree what the predilation, the further predilation, or you have any other modality to prepare such kind of situations?
Dr. Lin, what is your idea?
I think I will still using bigger balloon, because I think from the IVUS, the circumflex and the LED Ostian at least is 3035 by millimeter. So I think for safety or the better stent expansion, I think the bigger balloon or even after small scoring balloon will followed by the bigger non-compliant balloon for the lesion preparation. That is my opinion.
By the way, we published the paper after the rotor without cutting balloon or scoring balloon. Is it better compared to the regular balloon? And we see it better, meaning it seems to be like the synergy effect, meaning you have the rotablation and then you polish the surface and then you do the scoring or cutting balloon. We see more fracture afterwards. That's we found based on the serial OCT or IVUS picture.
Yeah.
Even in the prepare calc study, I think a lot of the percentage of the patients who had in the prepare calc trial who had rotational atherectomy, a large percentage of patients actually had post-dilatation with Scoreflex or with scoring balloons afterward, or cutting balloons afterward. I think it was up to 30% nearly, if I remember correctly.
Can I ask a questions maybe to Prof. Akiko and the panels? In the presence of calcified nodules, would you be more conservative when it comes to balloon sizing, stent sizing?
I think that's a good point because we see the calcified nodule, but remember there is eccentric calcium, and then other side is actually relatively normal, right? So that's, I think, typically we see. That's, I think, concern, but typically we don't see an issue because normal side is stretching well. Yeah, so I think actually the calcified nodule acute stent expansion was not too bad, but recent paper show us like even the good stent expansion at the end of the procedure, you may have the poor outcome if there is a calcified nodule. And then when we look into the follow-up IVUS OCT, actually calcified nodule reprotruding the stent slot or making the fracture. Because why the calcified nodule is, I do believe the calcified nodule due to the fracture of the calcium, and they always happen at the bending portion of the artery and more likely causing the fracture. So we don't know what's the best strategy to treat the calcified nodule yet. It seems to be really about people, but region. But go back to your answer. I don't think that's a very big concern because relatively normal segment stretching well.
Yes.
Okay, Dr. Fauzi, please.
Yes. Actually, I'm fans of cutting balloon, but at the time we ran out the cutting balloon in ourselves. So we used the scoring balloon. And then we decided to do decay crush strategy. This is our decay crush steps. First, we put a 3023 drug-eluting stent at 12 atm, just protruding to the left main, and then we prepare the 30 balloon with, we understand this is actually, we used to use a bigger balloon at the left main LED, but anyway, we try to crush it. And then afterward, we flare the circumflex stent until to 18 atm. We pull a bit the balloon and then flare to the 80 atm. And then afterward, we crush the circumflex stents used after removing the balloon. And then we perform first kissing balloon. And afterward, putting 3.5 DS from the LED to left main. And then followed by using a pot, using a 4.5 balloon. And then followed by second kissing balloon, 3.5 in the LED and the TO10 to circumflex. And because of the constant of expansion at the mid of part of the LED, we use the we do a distal optimization technique and followed by report. And this is the final result.
Excellent.
Looks fine, right?
Yeah.
And this is the LED. Post-PCI IVUS, the LED.
So this seems to be still all the stent segment because I see the neointima inside. And now it looks like that this is new stent. There is no more neointima inside. And I think a good expansion because IVUS is, this is almost 3.5 in terms of the diameter. And that's the ostium, I guess, is coming. And circumflex is 6 o'clock. And this is the left main. And left main, well opposed. And then I check the edge of the stent. And we remember the proximal segment was okay. Actually, that's protruding to the, yeah. So based on this picture, I think the overall LEDs really looks good. And left main is also good. That's it.
Okay, let's see the circumflex run, right? Or any other opinion regarding the IVUS LED left main?
I think it's perfect. So can see the circumflex
Okay.
So starting the non-stent segment, which is distal segment, and now you see the stent, there is no HD section, that's good. And actually landing is really good, meaning you didn't left some disease, right? And then we are coming to the proximal, and there is a calcified eccentric calcium in the 9, but I would say okay. And you see the ostium of the circ.
Maybe panelists will reveal what is it. Stop, let Akiko. Let the panelists reveal.
So it's a little bit difficult, IVUS. Yeah. I stopped speaking.
Yes. The quiz, this kind of quiz of the how the IVUS reveal of the circumflex. You got, I know it looks like you got it.
Yeah, so it has some malposition, that's right, at the ostia of the circumflex, but I think it's always not perfect at the bifurcation to stand like this all the time. If you try to collect everything like this, maybe 4 or 5 hours for the one case like this case. And what are other panelists? What do you think? Do you accept this finding of IVUS at the bifurcations?
Yeah, for me myself, I think I will accept it, Anurag, because like you mentioned, it's difficult to have 100% perfection, especially in this kind of situation. Of course, we see some what do you call it, the area which is not covered by the strut, but I don't know how max we tolerate this Akiko in terms of the IVUS. For me, I just accept it.
Okay, I think one thing which you comment, very important things. I believe you said somewhere not covered the stent. Is this correct?
Yes, yes.
You said, right? So you recognize somewhere even the two-stent technique was not covered by stent. You recognize, correct? Wow, that's really good. Okay, that's actually the question of this picture. It's a little bit advanced IVUS picture. I try to stop myself. Yeah, here. Could you stop? I almost could you stop the place where we are talking about?
Excuse me. Hold on.
Here.
Yeah.
Yes.
Stop. Thank you.
Yes.
So this is really the ostium of the circumflex. 12 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, no strut. That segment is a carina side. On the other hand, 9 o'clock, you see 2 layer. So I do believe when the first rewire to the circumflex wire is a little bit too distal, and then you bringing the strut from the carina side to the other side, making the gap at the ostium circ. And you picking up perfectly, you said, not covered strut. That's very difficult, IVUS.
Yeah.
I'm
so,
pleased.
Fauzi, you have to put the OCT on again. Or this kind of technique. Okay.
So, yes.
We have short time to discussion in this case. Fauzi, can you wrap up?
Okay. So this is a relook of LCX left-main IVUS. What does IVUS tell? As mentioned by Professor Akiko, that there is some at the carina side, it's not covered by the stent because the stent strut all go to the opposite side. But unfortunately, I recognize after finishing the procedures, after relook the IVUS, the ECG showed a very better ECG compared with the previous one, and the post-PCI echo showed looks a global contractility. Global contractility was fine, and this is 7 months later. I follow up. This still fine. The result, although there is some sort of misstep in the decay cross strategy. So that's what don't waste a good mistake. Thank you very much. Yeah.
Congratulations, Fauzi. So.
Yeah.
All right. So yeah, we are getting hot and hotter here, and then look like we have very nice discussion.
Yeah.
Sure.
Let me explain one more thing.
Sure.
I think actually this story tells us what is important, what is may not be important. We see this type of the super detail in the X-ray trial, and actually we see the gap in the two-stent technique is 11%. If I see very detailed, but nobody recognize 11%. But this case is completely fine. Patient, no problem, right? We don't know how it looks like inside, but this should be fine, right? So to be honest, I'm not sure how that's tiny thing effect of the outcome. And still the importance is a good stent expansion in each segment, right?
Yes.
But if you recognize better, and if you check wire position before giving the ballooning, rewire to more proximal, that's even better. But those things we have to consider in the future, but still there is no data such detailed effect of the outcome.
Yes.
So I have to say that is that is the typical good case for the left-main bifurcation PCI by IVUS guidance. Is as Akiko said, that is without IVUS guidance is that must happen is a disaster. But we didn't know what happened inside. So it's although there is just still a gap is without stenting side. So I believe that there is no issues in the future because it's a quite nice minimal is a stent area. So it will not happen is the blood turbulence or something like that. But if the stent area is small in the bifurcation left main, so it's a blood turbulence makes something is thrombus or is the other things. So this case is really nice and typical is IVUS optimization for the left main bifurcation PCI.
Agree.
Great.